And I want to welcome everyone here to the support group meeting and to the webinar. No, it's okay. It's okay. Come on in. This is the 20th anniversary of West Nile virus gaining entry into North America. And we've come a long way together. Obviously, there's a long way still to go. I see living testimonials what the virus can do. Mr. Terry was our second patient ever diagnosed in 2002 with West Nile virus poliomyelitis. So welcome, Mr. Terry, 20 years, almost 20 years ago. And then running to Dr. Bush over here, who's actually a living legacy of what proper treatment can do for this particular ailment. I'm going to review the last 20 years. You know what? One second here. Brandon, how do you? Oh, here. Okay, so here. So again, New York City outbreak in 1999. There were native and exotic birds that were decimated. In the zoo were decimated. Horses were affected. There were a number of human deaths, and this was attributed to a paralyzing peripheral nerve involvement called Guillain-Barré syndrome. We now know that it's no longer Guillain-Barré syndrome, and there were cases of meningoencephalitis. This is the 1999. Most of New England by 2000, 2001. I actually, in retrospect, think I saw my first case in 2001, and I missed the diagnosis. And she was the wife of one of our orthopedic surgeons, and we just never came down with the diagnosis. We never even considered West Nile virus as a possible pathogen in 2001. But next year in 2002, we were actually had a major epidemic, at least east of the Mississippi River. And in Mississippi, we had over 200 cases and a number of fatalities. And after that point, it became literally global. This is a map from 2010 showing that 6 of 7 continents now harbor the virus. It is endemic in those countries, in those continents. The only exception being Antarctica. It's probably because we haven't looked in Antarctica. So what's new with West Nile virus, or actually what is West Nile virus? It's an arbovirus. It's an arthropod virus. It can cause inflammation. It can cause infection. It's called a neurotropic virus because it actually targets the nervous system neurons once it gains entry into the human body. The genus is flaviviruses. It's a single-stranded RNA virus, and there are a lot of famous flaviviruses. Dengue is one. Dengue last year, and it was not a particularly bad year, infected 200 to 300 million people globally, worldwide. It used to be a high mortality with this particular virus, not so high anymore now that we're learning how to manage the problems with this, their more neuroinvasive form. Zika virus, I think we all knew about Zika virus. It came and literally over a period of about 2 years became a global healthcare crisis. It actually threatened the shutdown of the Olympics in 2016 in Brazil. Yellow fever virus has a history dating back to the building of the Panama Canal, which actually forced this country and the government to come up with a mandate to find and to develop a vaccine. after the Panama Canal was completed, they couldn't get anyone to move into the region. And certainly families were not bringing anyone, and so they literally had to actually put the money where it counted, and to develop the resources also, and to develop a vaccine, which we had within about 15 or 16 years of the building of the termination of the canal in about 2015. Japanese encephalitis virus is a very wicked virus, and again, infecting hundreds of thousands. It's transmitted to humans by mosquitoes. Other forms of transmission are possible, okay, but typically not through direct contact. There are a number of new modes of transmission. I've been through this before, but blood products, we now screen all blood donors. I've had several cases where the West Nile virus was actually detected in the blood donor during blood donations, and they become symptomatic literally within days. Organ transplants, obviously the virus is hidden in a patient who has immunosuppressed immune system, it can then be transferred to other people, the recipients of the organs. Transplacental from mother to fetus, that's the rule, not the exception, particularly for the smaller RNA type viruses. Breastfeeding there are reported cases. Lab workers, occupational exposures. Dialysis related, which is kind of a negative testimonial, suggesting there were several cases, and apparently the machinery was not sterilized before it was reused. And sexual transmission is still no confirmed cases, but we've seen several husband-wife, girlfriend, boyfriend cases, which certainly raises a concern. We know that Zika virus, which is a very similar in terms of structure, flavivirus, is clear sexual transmission, and now we're beginning to suspect it's probably true for West Nile virus also. So this is a cycle in nature. The female mosquito is the vector. The female mosquito is the one that bites and draws blood. It needs a blood meal for the eggs to develop properly. The host in nature is the bird populations. It does spill over, and we humans and other, particularly mammals, are considered dead-end hosts, which means that we cannot transmit, person to person, at least not easily, or animal to person, or back and forth. Once the mosquito bites, there's an incubation period. It's typically 4 to 10 days, but it's ranged from 2 to 15 days. And there's a war raging inside your body with the innate immune system trying to destroy the virus before it gains entry into the central nervous system. Most of the time, in fact, the vast majority of times, the immune system stops. So that about 80% of the time, the patients are asymptomatic, don't report any symptoms, and essentially presumably build lifelong immunity after that encounter. This is the CDC West Nile virus disease classification as of 2015. We'll concentrate here, and I'll show you a case report of a West Nile fever, a mild self-limiting infection. It's often described as a summer flu. And by definition, neuroinvasion, which means, again, gaining entry into the central nervous system, does not occur. This is the pyramid of the reported cases. Approximately half of the cases that come to medical attention are going to be neuroinvasive. Half will not, and we presume that about 80% of infections cause no symptoms and confer the lifelong immunity. So this is case one, 34-year-old woman. She developed a summer flu type of presentation, fever, chills, maculopapular, which is just a viral type rash in the face and limbs. She also suffered from body and muscle aches and pains, worse in the lower limbs. There were joint pains all over. Headache was mild, but it can, in a lot of cases, even with West Nile fever, be a severe pounding, throbbing headache. She had GI symptoms that developed, particularly diarrhea, but nausea, vomiting, constipation are also common in patients who develop West Nile fever. And there was a question of whether or not she had some swollen lymph nodes. Oftentimes patients do, but most of the time they miss the fact that their lymph nodes are swollen. Classified by West Nile as West Nile fever by the State Health Department. I'm going to come back and revisit that classification toward the end of this lecture. Okay, so neuroinvasive disease, high fever, worsening headache, confusion. It's typically focal muscle weakness, paralysis, ataxia, which is a problem with the rate, range, and force of movement. Tremors develop, seizures, something called dysautonomia, which affects the autonomic nervous system. I'll show some examples of that also, and other focal signs. And that can result in this acute flaccid paralysis, respiratory distress, stupor, coma, and death in 5 to 15%. The elderly and the immunocompromised are most affected and most likely to have the severe manifestations. So, virus meningitis. This is a classification scheme that I'm not really sure I've ever seen. I'm not really sure why it was broken into the neuroinvasive form, was divided between meningitis and encephalitis, because I assure you, a patient who has meningitis is not going to be able to perform serial sevens. They're going to be confused, and I've never quite understood, exactly what delineates a meningitis picture from an encephalitis picture. But in either case, a prognosis, as they have determined, is typically favorable if all you have here of the lining around the brain without actually gaining entry into the brain. Again, it's one of those things that looks well when we talk about classification, and I'm not sure exactly how that presents in the real world. Encephalitis is a severe form, altered consciousness, confusion, coma, focal neurological deficits. And so 15 years ago, these were combined and called meningoencephalitis. Some of the seminal papers referred to as meningoencephalitis, and now it's kind of subdivided. But I'm going to show you an example of the encephalitis in just a moment. Fatality 5 to 15%, and immunocompromised and the elderly, the most affected. So this is a 71-year-old woman. This is Dr. Bush. Okay, she's in the audience. She developed a febrile illness, 102, 103 degree temperatures, and then she rapidly progressed. Severe generalized weakness, so weak she couldn't lift almost any arms or legs, and she quickly became confused and became delirious and stuporous. So stuporous refers to a state where you need continuous stimulation to remain awake. So when I examined her, she was, to the untrained eye, she would be drifting in and out of coma. But I had to actually apply noxious stimulation to get her to arouse. And it was never a full arousal. And in fact, she has no memories of it, because there were things I did with her ears and her nose, and even the eyes. And she would, she tried to remove her the head from the offending noxious stimulation, which told me she was stuporous. But once I left her alone, within a minute or two, she would kind of drift back into essentially quietness. She also lost her speech. She had these bulbar signs. She had difficulty swallowing. Initially, it was slurring of speech, and then it was followed by anarthria, which means she really could not verbalize anything. And she had disconjugate gaze, meaning that one eye would look over here, the other one would not necessarily follow, and vice versa. When you see that type of, we know that we're dealing with a brain stem phenomenon. Something is going wrong in the brain stem and the cranial nerves that control these types of functions. So her consciousness remained impaired for 9 days. And this is what the neurologist, Dr. David Sinclair, wrote. I got this from the chart at Baptist Hospital. Patient is critically ill with fulminant neurological deterioration, with potential for further deterioration and possibly death. It was at that time that I actually got involved with her case. And since 2002, we had actually been making recommendations to treat this type of presentation with really high dose corticosteroids. This was after just an open dialogue with the Centers for Disease Control, and they were assuring me that the virus does not remain latent or hidden in the human body, and that the West Nile virus cannot set up a persistent infection. And so there was one paper published in 2002, in late 2002, CDC, and it gives us a typical example of how difficult it was to actually isolate the virus after it developed neutralizing antibodies. In other words, it can't be done. They looked at 2,700 cases dating back to 1999, and in late 2002, only one case, that was the first case, where they were actually able to isolate West Nile virus from the human body. It didn't count. It didn't count because this was a woman who had non-Hodgkin's lymphoma, 3 chemotherapeutic agents at the time that she developed West Nile virus infection. So the take-home message is that once neutralizing antibodies are developed, then the virus is no longer playing a pathogenic role in the human body. I kind of wish I would have known that a number of years earlier, but in 2002, I would wait for 14 days, for 2 weeks, before making a recommendation of high-dose corticosteroids. I knew that the virus was hard to isolate. CDC was telling me it didn't hide in the body, and that it was actually easily destroyed by the immune system. Nevertheless, I didn't have the courage to say, the instant that you're diagnosed with West Nile virus, you should receive an immunosuppressant. That is almost counterintuitive, but the reality is that is exactly what I'm recommending today. In all cases, once you have a diagnosis, the diagnosis is dependent on the end product of not the early immune system, but the later one. It's called adaptive immunity, and we look for IgM antibody. That occurs after this incubation period of innate immune system fighting off or trying to fight off, and in most cases, 80% of the time, successfully fighting off the virus. But the other 20% of the time, half of those patients develop neuroinvasive form, and the West Nile fever. So with Dr. Bush, there was no specific treatment. That's actually the kind of the status quo. Complications of West Nile. What I do and the recommendations I've been making are recommendations that are shared by clinicians who see these cases and who know and have done exactly what I've done. I was not the first one to actually start using steroids. I probably have used more steroids so than anyone else, and the outcome has never been negative, meaning that the steroids don't reactivate the virus because the virus is essentially gone at that time. It's eradicated from the human body. It's cleared by the adaptive immune system and by the neutralizing antibodies. So I actually was able to convince the doctors at Baptist that it's time to begin a 5-day trial of super high intravenous corticosteroids. And that is exactly what we did. We gave her 1,000 milligrams daily in the morning. After that first morning, late day 1, she actually started moving on her own. And she had some spontaneous eye opening. Late day 2, after 2,000 milligrams of infusion, she was awake and she was responding to commands. Not fully, but awake and responding to some commands. Thereafter, she remained awake and responsive. She actually gave a very nice presentation about this ordeal at one of the Mosquito meetings about 3 months ago. So, Dr. Bush? Okay. And I have to tell you that she will give credit where credit is due, and that's the gentleman right to the left of her. There every minute of the day. I thought he was a clone because he never left her side, and that was one of the reasons I was actually able to convince the doctors at Baptist to allow the high-dose corticosteroids, because there was always someone vigilant by her side. If she had not had this person and this advocate, they may have said, no, we can't watch her. But he actually gave great descriptions of what had happened, and so thank you also. What exactly was going on in the body, in her body? What happens is the West Nile virus is not destroyed by that innate immune system. It starts upregulating a number of pro-inflammatory proteins called, this is one, S100B, and we've written several papers on this. This is a high mobility group box 1. Scientists are horrible at naming terms, but this is HMGB1. Interferons are activated, and cytokines. Cytokines are typically pro-inflammatory early on, and these are all part of the antiviral immune response. And again, we know that it protects. 80% of the time, it does what it's supposed to do. The virus does not leave a trail in your body. So, what went on in her brain and the brains and spinal cords and the bodies of all other patients? Well, there's no doubt that the direct attack of West Nile can destroy neurons. It can destroy portions of your spinal cord and give rise to the poliomyelitis or acute flaccid paralysis variant. But it also does something else. It actually causes a antiviral immune response should have turned off. In Dr. Bush's brain, it should have been limited. Because by that time, after starting the corticosteroids at day 10, keep in mind that was 20 days or 30 days after she became infected with West Nile, and she was already IgM positive when she was the day one that she was diagnosed with this condition. And so what happens is that some patients, probably the majority of you who were infected here, they don't turn off the antiviral pro-inflammatory response. Something goes on that keeps it going for a persistent amount of time. And that, in my opinion, is what explains why even back in 1999, 2001, there were already papers being published about West Nile virus causing lingering, protracted, prolonged, recurrent symptoms. And this is why in 2002, when we started seeing 3 consecutive cases with poliomyelitis, this is why I was talking to state health officials and to CDC that the virus has to be lurking, hiding, latent in the human body, and they were saying no. There's zero evidence of that. Even today, there's no convincing evidence that the virus lurks in the human body or that it can produce a recurrent infection. So we had to consider alternative pathogenic mechanisms. And that's what I and other people who see these patients have actually done in the past 2 decades. We now know that there is a post-infectious pro-inflammatory state. Probably the group that has contributed most to this is the 2 programs in the Houston area, the Baylor College of Medicine with Dr. Christy Murray, and the University of Texas, where I actually trained with Dr. Haspoon, Rodrigo Haspoon. And so they actually came up with a nice paper. This is it, where they were actually looking at one symptom, fatigue. They defined fatigue included a huge wide range of symptoms, which are very common in most patients with West Nile virus infection. And they found that 31% of patients who had prolonged symptoms, defined as more than 6 months, and for an average duration of 5 years, 1/3 of these patients had these elevated cytokines, the same cytokines that are formed day 1 or day 2 or day 3 after exposure to the virus, suggesting that these cytokines can, substantial group of patients remain at high levels for a very, very long period of time. So what is the other evidence that there is indeed a post-infectious, meaning after the infection, after the virus has been removed, that there's a post-infectious autoimmune type of process. Several years ago, we described 6 patients, and here we hypothesized who developed myasthenia gravis. Myasthenia gravis, or MG, is one of the classic autoimmune neuromuscular neurological diseases. We probably have written more, as a medical group, has probably written more about the autoimmune problems of MG as any other autoimmune condition. So very well studied. Well, 6 patients came down with myasthenia gravis, all 7 months after having neuroinvasive West Nile virus infection. And so back in 2000 and see, it was March 2013, 2014. Well, back then I thought that maybe what was going on was something called molecular mimicry. So molecular mimicry means that you have an attack by a bacteria or a virus, and your immune system launches its, antiviral or antibacterial immune attack on trying to destroy the pathogen. And then afterwards, the pathogen is gone, the bacteria is destroyed, the virus is destroyed, but you still have the same antibodies lurking in the body. And so it's like they then tried to attack anything that was similar to the bacteria or the virus. And what happens through molecular mimicry, this is how Guillain-Barré syndrome comes into play in terms of the history of West Nile virus infection. In New York City, there were 7 deaths. No one knew why they died, but they had this paralyzing illness, and they figured, well, something about the virus triggered the immune system to start attacking what we call its own body, the host. And that by definition is an autoimmune disease. And so they thought it was Guillain-Barré syndrome. And so I thought maybe it was molecular mimicry, and we were actually, this is myasthenia gravis, and again, the issue of molecular mimicry. But we were actually, I was wrong, okay? And I knew there were some very important cases back in 2013, 2014, and we waited. This is a paper that we were just got published in 2018 with the Mayo Clinic group. It took 5 years to find the patient we were looking for. And this is a patient who had stable, what we call ocular MG or ocular myasthenia gravis. And it had been stable for years in this patient. He didn't need steroids. He didn't need any type of immunosuppression, and he was doing well with ocular myasthenia gravis. Sometimes you don't need to even be treated, and the typical manifestations are if you overdo it, you have a little bit of a lid lag, what we call eyelid droop, and your eyes can get out of whack, so you look to the right, and sometimes you see double, look to the left, all the way to the extreme, and sometimes you see double. That's ocular myasthenia gravis. It had been literally stable in this patient, and 3 months after he had West Nile virus infection, he had a myasthenia gravis that almost killed him twice. So there's something had changed about the immune system 3 months later in this patient. We went from stable ocular MG to MG crisis. And then he needed IVIG, he needed plasma exchange, he was placed on a respirator several times, and then he had to be treated like most patients who have this severe form of MG, of myasthenia gravis. We actually needed because we now we're saying that this was not due to molecular mimicry. By definition, it can't be, but to the concept of a post-infectious pro-inflammatory state. Now, I want to talk a little bit about the group at the University of Southern Miss, headed by Dr. Bai, B-A-I. He's the only scientist in Mississippi who actually can handle the live West Nile virus. I don't know if that's changed, but hopefully other scientists will be able to, basic scientists will be able to manage and handle the virus also. But his group looked at something called osteopontin. Now, osteopontin is one of these pro-inflammatory molecules. And so I'm going to read here, the pro-inflammatory chemokine osteopontin, OPN, is induced in multiple neuroinflammatory diseases and is responsible for this is a white cell, this immune system recruitment to the site of its expression. In this study, we found that West Nile virus infection induced OPN expression in both human and mouse cells. So OPN is produced. So what exactly is OPN? OPN, to literally the rest of the world, is a cancer marker. So for years it's been known. I'm going to read this. This is a review paper back in 2014. OPN implicated in promoting invasive and metastatic progression of many cancers. Implicated as a prognostic and a diagnostic marker for several cancer types. And it's being explored as a possible target for treatment. In other words, some of the cancer treatments, they're trying to destroy OPN from essentially contributing to the genesis, which is really what it does. So I was actually working in Mayo Clinic when I heard about this particular case. And then when I came back here, I was pleasantly surprised that there was another case of 2 tumors that developed after West Nile virus neuroinvasive disease. So this was and I'm going to read to you here, the same immunoregulatory proteins, the same proteins that fuel neuroinflammation, for example, in West Nile virus infection, can also promote tumorigenesis. That's a true statement. Viral infection was a precursor, it occurred before, to the development of aggressive brain tumors in these cases. We describe a potential mechanism where the presence of tumorigenic proteins, this OPN, in the microenvironment induced by West Nile virus may contribute to development of aggressive growth of these tumors. Now, this was an 81-year-old man. The first MRIs here under letter A were the MRIs when he had West Nile virus encephalitis. Half the time, the MRI scans are going to be normal, and half they're going to show some areas that are with abnormal signal. This was a relatively normal MRI. This is 2 years later, and the neuro-oncology team at Mayo Clinic estimated that this tumor here on the different views probably started within a year after the onset of West Nile virus infection. This here is closer to 2 years toward the end of the patient's life. This is a 35-year-old man who developed West Nile virus neuroinvasive disease. This is the initial MRI, but this is 8 months after West Nile virus. The actual MRI was essentially showed evidence of a meningoencephalitis, no abnormal enhancement, and again, it showed some abnormalities that were attributed to West Nile. Patient went home, began to recover, and then 8 months later, he developed pounding headaches and vomiting. A scan was repeated, and this is what they saw. This whole area here in the middle is actually abnormal in terms of its signal. This is called hydrocephalus. The fluid ventricles inside the brain expand because something essentially is damming the flow of the fluid. And here in the spinal cord, little dots here, let me see if I can find it here, right adjacent to, right there, there's a little dot, and that was evidence of the abnormality, abnormal signal. At that point, they did not know what it was. And this was 1 year later, you see, you have literally, it was progressive, what we call leptomeningeal disease. and the enhancement here was completely encasing the entire spinal cord and the entire brain. This tumor was also known as a hamartoma. This is essentially a relatively benign tumor. When we see it, depending on where it is in the brain, sometimes they just watch it and don't go in there and remove it. But for whatever reason, this particular neuroepithelial tumor became extremely malignant in this patient, and this is essentially why this was published. So OPN, you follow the white line, it does contribute to chronic inflammation. Chronic inflammation is known to be tumorogenic. This is not new. So people who have hepatitis C, for example, mechanism that years later it becomes a liver cancer is because of the chronic inflammation in the liver. It's not a good thing to have chronic inflammation, and it can lead to tumorigenesis. We're going to have to do a lot more work to try to determine whether or not there's truly an association. Okay, we know other viruses, for example, Burkitt's lymphoma can be essentially triggered by exposure to some viruses, but with West Nile, we also know now that it does produce tumorigenic microenvironment. So acute flaccid paralysis. This is the so-called poliomyelitis variant. And I'm going to give you an example because this is kind of a striking example. Although, Mr. Terry, I could have used your data. But this was a 49-year-old man at that time, nausea, vomiting, headache, diarrhea, dehydration, no confusion or a little bit of confusion. Right arm had an acute flaccid paralysis. His right arm was literally hanging lifeless by his side, and he was right-handed. He didn't have any reflexes. He did not have fever. He had no pain, no numbness, no altered sensation. He was diagnosed, he went to the emergency room 3 times. He was diagnosed with food poisoning, brachial plexus problems, either nerve problems, spinal cord injury, stroke, and finally, because he kept coming back, malingering. MRI of the brain and cervical spine were normal. That there couldn't be a true anatomical reason for his lifeless limb. Part of the fact is that no one in this era has ever laid eyes on a victim. Okay, if this particular individual had this same presentation in 1950, I assure you they would say, "Oh, yes, sir, you have poliomyelitis. Take care." But so the spinal fluid was never done. And he was discharged from the emergency room 3 times. And you can see here, when I saw him, this was about a month and a half after the onset of the paralysis. This is his left upper limb. And you can see that already this is kind of lifeless and kind of wasted. Here, I'm asking him to go ahead and raise both arms overhead, and you can see left arm functioning normally, and you can see the atrophy. This is just the ball of the joint here, and virtually no muscle on the right upper limb. You can also see the early onset of atrophy here in between the ligaments and tendons in his right hand. Now, I'm an electromyographer. I'm a clinical neurophysiologist in addition to a neurologist. And one of the things I do is literally measure the sizes of motor responses. And so let's look at the big deltoid muscle here on the left had a 7 millivolt response, 7 millivolts. So 7 millivolts will be this big or this high. The right axillary had 0.1. So this patient had lost 98%, 99% of his connections. the deltoid muscle. And that translates into a severe, he had no voluntary activation of any muscle fibers in the deltoid. So based on these electrodiagnostic criteria, this was a case of West Nile virus poliomyelitis. This was the third case in literally 3 consecutive weeks. And we found the same thing in Mr. Terry and also in the first patient who presented with this condition. We also were the first group to actually obtain pathological confirmation. This is a nice, healthy-looking motor neuron. The nucleus is right smack in the middle here. Happy, okay? This is the typical feature of what we saw in patients who died of poliomyelitis form, or the acute flaccid paralysis form of West Nile. This is a very swollen motor neuron. This is a very eccentrically located nucleus. It should be smack dab in the middle. It's completely off to the side. And this motor neuron in a few days will look like this one here. The debris removed by all the debris-eating white cells and macrophages of the immune system. 13 years later, he's still very weak in the right upper limb. He became left-handed after that. He had relatively good recovery in forearm and hand muscles. That's lost only 60 to 80% of the neuronal connections based on this amplitude criteria, meaning that you can lose a whole lot of nerve connections and still have a, okay? Lose a lot of connections and still over time have a very good outcome. You just can't lose 95+%. I want to just mention that West Nile virus is a neurotropic virus. It attacks neurons, and I showed the poliomyelitis, the attack on the spinal cord. This is an example of a patient who had the attack was in the brainstem higher up. The brainstem motor neurons are also targets. This particular individual, he had bilateral profound weakness, paralysis. The muscles that chew, muscles of mastication, were also paralyzed. And so literally the physical therapist had to do was try to tape the jaw, because otherwise gravity would just lift it down, or pull it down, okay? And he was going around with, mouth agape this way because no muscles of mastication. He also had dysphagia and could not swallow. So that's what neurotropic viruses do. Now I want to switch over to autonomic nervous system because this is something relatively new. There have been virtually no published papers except one case report and our West Nile virus reviews that have actually or mentioned autonomic nervous system dysfunction. The autonomic nervous system controls everything that's automatic in your body. So heart rate, blood pressure, breathing, digestion, bowel and bladder control, sweating, pupils, erections, and everything that's automatic is autonomic nervous system control. If you have West Nile virus infection, it can give you irregular heart rate, palpitations, irregular rhythms, sudden death. One of our first cases of where we knew the autonomic nervous system had been severely affected was a patient who was on the 5th floor of this hospital for about 3, 4, 5 or 6 weeks. That was a time when we actually could keep patients, 5 or 6 weeks. Anyhow, I remember in a period of 1 day, I went up there on. We used to have stat or any physician stat calls at that time. And the first time I ran up there, his heart rate was like 180. And second time I was called up there, the heart rate was down in the low 30s, and blood pressure was all the way up, all the way down, hypotensive, hypertensive. He also had a complete bowel. They thought it was a bowel obstruction at that time. Thankfully, they did not operate because his blood pressure and heart rate were so essentially dysregulated. But he also had, again, the gut was completely essentially shut down. Bowel and bladder the same way. He had shut down sweating, and he had every evidence that he had profound dysautonomia. Okay, so he was actually had the poliomyelitis variant. He had acute respiratory failure, mechanical ventilation for 8 days. He had triplegia, so 3 out of 4 limbs were essentially affected by the poliomyelitis variant. Again, labile blood pressure. Oh yeah, I remember I mentioned this from time to time, but I remember when I first walked into the room, and he was actually lying supine in bed, but I thought he was having difficulty raising his head so that we could talk, and maybe some discomfort. And I was at the foot of the bed, and I asked the nurse to essentially hit the bed so that the head of the bed came up. The head of the bed came up, and he stopped talking. And I said, "Mr. So-and-so, what happened? What happened?" I said, "Check his blood pressure." And someone said, "Lower the bed." The bed was lowered. He started talking again. And I hated to do it, but I said, "Let's go ahead and raise the bed again." And Mr. So-and-so keep talking to us. He was talking, lapsed into unconsciousness. Lower the bed again, he's talking again. So it's striking, and you never forget it if you see it. But this is also kind of a testimonial. He was discharged 3 weeks later, and he died suddenly. We know from, this is from the autopsy work that was done by Jonathan Fratkin, who's part of our group here at UMC, and it shows that, yes, you can have, these are cervical sympathetic ganglion cells that are being destroyed. They're actually being essentially consumed by these phagocytic neurons are being consumed, and they will be removed as part of all the debris, essentially the garbage cleaners. And so we know that issues here, this controls things like heart rhythm and heart rate, and also blood pressure. And so it's really no surprise. We've known from just hamster and mouse studies, this is an infected example. You see literally right here, that little arrow here and here, compared to the normal gut, where they inject non-virus, and you start seeing what happens to the intestines in patients who are infected with this virus. So I want to talk a little bit about Amanda. We actually did a webinar on her before, kind of our poster child for what the virus can do to multiple organ systems. Some of her progressive symptoms: one day I was tired, the next I couldn't even move. Worsening symptoms, the glands became more swollen. She also had a rash, pressure in my head like nothing I'd ever felt. Head and neck rigid and stiff. This is part of the meningitis presentation. So weak I couldn't suck through a or swallow, again implicating brainstem. Shaking, can't walk, can't hold my head up, glazed eyes, feel like death. She was confused because she actually had very little or no fever. He's one of those cases that I also think was classified as West Nile fever. I will have to confirm that with her because she was not hospitalized right away, or if so, it was just for a very short period of time. So how did this post-infectious, pro-inflammatory state affect Amanda? It's common. It's very common. I can't believe that there haven't been, dozens of papers on it, but also very under-recognized. So she also had delayed neurological deficits. And the dysautonomia actually became more profound several months later. She shut down her gut. This is gastroparesis. She had heart rhythm problems, orthostatic hypotension. She gets up, she feels lightheaded, like she's going to pass out. Other times she gets up, doesn't feel lightheaded, but she had tachycardia. This actually is called postural orthostatic tachycardia syndrome. And so heart rates would go up to into the 180s. When she stood up, she felt like her body was not regulating her temperature. Because Megan now had the same identical symptoms. My body's not regulating temperature. She started losing her hair, toenails falling off, and dry mouth. This is an example of Megan before and after West Nile. In fact, this is what happens to her even today. She was infected in 2013. Whenever she has a viral infection, she seems to go through this period where she's going to have a kind of a transient shutdown in her gut. Unfortunately, she's also a kindergarten teacher. I've asked her to get another career, but she's stubborn in a good way. This shows again what we knew about that even beforehand. This talks about cardiac dysfunction in hamsters, but she also had, I felt my heart was starting to race and slow down. She had marked fluctuations in heart rate unrelated to physical activity, not that she was running or whatever. Her maximum was 197, and her minimum 30 beats a minute, all in the same day. And again, not because of physical exertion. She saw a number of doctors, and she's a very in the sense that she has multiple organ systems affected. And there were a number of doctors who recommended, and this is a quote, start training and running to reset my heart. You can only imagine how angry I felt. I'm not sure what it means to start running to reset your heart, but and the other thing is she was actually, her degree, college degree at USM, she was in dancing. So she was very fit. And so we actually saw her, and I brought her to Mayo Clinic. It's the only place her insurance company would actually allow us to do this immunotherapy with IVIG. This is her receiving the IVIG, and it led to a significant improvement across the board in all her symptoms. The dilemma I have now is that I really don't know. She had such a good response to IVIG. I really don't know when to give her a drug holiday. I mean, very few people can be on IVIG indefinitely for their lives. It's typically those who are immunosuppressed because of hereditary immunodeficiency who are on IVIG for many years. And so I'm going to try to talk her into, and I hope she's listening, I'm going to try to talk her into just seeing what happens with the drug holiday. But she's got some very legitimate concerns about staying on IVIG. So specific therapy, literally in 2002, in 1999, it was supportive care. And that was it, period. Hospitalization, IV fluids, nutrition, ventilatory support if needed, prevention of secondary infections, good nursing care, but no good human clinical trials. There are still no good human clinical trials. But we now have anecdotal testimonial evidence, and not just by me, by a half dozen clinicians who see these patients, that immunotherapy control this post-infectious pro-inflammatory state with high-dose steroids, IVIG, or other immunosuppression. So you have to go out there. You're the troops now. You're educated. You have to go out there and actually try to educate your doctors. Because again, it's not going to be, it's counterintuitive that I'm coming to a doctor and saying, yes, your patient with viral encephalitis, let's immunocompromise that patient. They have no idea of what's happening, but there's actually a biochemistry that clearly supports that type of intervention. Because it is counterintuitive, and very few people want to do it. I didn't want to do it fully. I had to wait weeks. Then I treated aggressively with high-dose corticosteroids any new neurological deficits. But even then, in my opinion, I was wasting 2 weeks, where there could have been, presumably the improvement could have been more. So let's get back to Megan. So she was diagnosed with West Nile fever. But the classification scheme missed a few things. I think you know that you actually were counted as a fever case. Okay. So she had all the classic symptoms, but there were a number of very, very prominent symptoms that were just overlooked. Her fatigue was very severe, and when I got involved, it already month 3 after the onset of symptoms. She had marked dysautonomia, just like Amanda. She had palpitations, tachycardia, blood pressure changes. She also has what would be a textbook description of autoimmune POTS, the autoimmune postural orthostatic tachycardia syndrome. But no one ever even asked her about autoimmune POTS. She had hand tremors. I can barely write my name. It's supposed to be your quotes, so if they're not, let me know. Okay. She had difficulty with hand-eye coordination. She had right leg muscles that were jerking and jumping. I've seen the jerking and the jumping, and it truly is jerking and jumping. We had one young man in his 30s who his trapezius was literally doing, almost looked like he was voluntarily faking it. Until I put a needle into it and took videos and realized, oh my gosh, now this is what's called a myoclonic jerk, or a myoclonic-like jerk. It's a central nervous system phenomenon. Hand tremors. Hand tremors arise because of basal ganglionic disorders. The basal ganglia sit right smack in the middle of the brain. So tremors, jerking, jumping. So I examined her, did a thorough neurological exam in the right leg. Right thigh, right leg, anatomical leg muscles were weak. Not severely weak. This was not like Mr. Terry or the other gentleman I presented with polio. It wasn't a flaccid paralysis. It was acute. It came with the infection, but it was not a flaccid paralysis. But I knew that if she had this type of focal weakness in the setting of a neurotropic virus, that I knew exactly what the needle examination was going to show before even doing it. And this is the type of evidence that we're going to take to state health departments, to take to CDC, so they can change and get up to date with their classification schemes. Right now, they're 20 years behind. So the video, I saw her video, it confirmed involuntary myoclonic jerks. In fact, her quadriceps, the entire length of one of her quadriceps muscles from the upper hip to the knee was simultaneously doing this. You could see this. So her accurate classification was West Nile virus, neuroinvasive disease, and poliomyelitis. Because that's the way poliomyelitis is going to present when you only destroy 30, 40% of the motor neuron. So this has been going on for 20 years, I absolutely assure you. And the problem with the classification schemes is that they're missing many cases of neuroinvasive disease. And I frankly, I'm tired of looking and reading West Nile virus papers that begin that neuroinvasive disease is rare. It isn't rare. It's half of reported cases. It is not 1%. It never was 1% because of these types of mistakes. Every classification scheme ever designed sacrifices accuracy. This one in particular does it worse than most. So, are there better ways? Is Megan the tip of the iceberg? And the answer is, yeah, she's the tip of the iceberg. I've seen about 200 cases, and yes, she's the tip of the iceberg. And now, Beverly, how, by the way, let us know. And welcome, Beverly. I haven't seen you before as a patient or as a support group member, but I know you were infected in September 2018. And let me ask you something. I saw your antibodies, so that confirm an acute West Nile virus infection in the clinical context of you having the symptoms that you did. So, are you counted? Were you counted by? Okay. So. Anyhow, so I'll ignore that, but there are better ways. There are much better ways of looking and trying to diagnose a neuroinvasive disease case. There's a whole biochemical trail. We've done it with a protein called S100B. This group from Fraser, I think he's the Russian virus research. Ironically, when we looked at about 60 cases of West Nile fever, 42% of them had a protein in their floating around in their bloodstream that comes from the brain or spinal cord. 42%. And this protein got there because of injury to central nervous system, to brain or spinal cord. The group from, I think they're from stationed out of Greece, looked at HMGB1, the high mobility group box 1, okay? 41% of their cases had HMGB1 in serum. It's another protein, we never looked into HMGB1, but it's another protein that is derived from neurons in the brain or spinal cord. And in 41% of their cases of West Nile diagnosis, West Nile fever, this is again, this is the other side of the world. They're coming up with a very similar number for misdiagnosed cases. We can use this type of information. The protein biomarkers. I'm going to finish this talk just by thanking the people here at Methodist Rehab, our colleagues at the University of Mississippi Medical Center under the direction of Dr. Vig, the colleagues with Dr. Bai at USM, and Mississippi State Health Department. Essentially, we could not have done much of what we did and accomplished much of what we accomplished without their help in the early years, and the Mosquito Illness Alliance. And so I'll be happy to field any questions. I suspect there are going to be some questions, I hope. Yeah, Beverly, go ahead. So you had a case of PMR is polymyalgia rheumatica. Yes.
Is there any connection?
There's going to be a connection if your case of PMR developed after West Nile virus infection.
No, before.
Okay, okay. So PMR is one of those kind of poorly understood, presumably autoinflammatory or autoimmune disorders. And probably what it's saying is what ultimately I think we're going to find in most patients who develop. Who develop West Nile virus infection. You interrupted my here. So there's something about your immune system that gave you PMR, polymyalgia rheumatica, and probably allowed West Nile virus to gain entry into your body, and you weren't able to fight it off. Yeah.
Thank you.
You're welcome.
Leis, am I understanding that you recommend the steroid treatment how soon after the diagnosis?
I'll tell you, the fact that CDC published a paper in their journal, and they looked at about 2,670 cases. And back in the early years, the only way of diagnosing a case was still IgM. So they were doing the IgM, using that as the standard. So they weren't able to isolate virus in any of those, that 2,700 group of patients who had documented WNV. And so that tells me that the virus is no longer there at the time the neutralizing antibodies have been formed. Neutralizing antibodies do form. They form later than the innate immune system trying to keep the body from invading, keep the virus from invading. And again, in 80% of the time, it works. The innate immune system kicks in early. The adaptive immune system comes in later. And by the time you have the neutralizing antibodies, the IgM, in particular, I would say there's, if you can't find it in 2,700, you can't find evidence of a viable virus in 2,700 cases. That is as good a bit of information as you could possibly have. I would say at that point, you have a diagnosis and you have clear evidence. You have not been able to localize any viable virus. At that point, I would start treating them with high dose steroids. I would not wait 2 weeks anymore. Pardon me?
Ask questions if I had.
Oh no, that's okay. That's okay. So the answer is yeah. I probably field a call every week, and it's maybe once or twice a week from patients out of Mississippi who actually talk to Amanda or Sharon at the MIA, and they give me the information, and that's my recommendation is going to be based on that. Enough evidence that even from other flaviviruses. If you look at the dengue literature, there's about 12 studies years looking at high-dose corticosteroids. And the ultimate conclusion is a very nice review that was published just a few years ago. And in the review, they came to the conclusion that proper doses of high-dose steroids, really high-dose steroids like the kind that we were giving to Dr. Bush, like the kind that neurologists routinely give for treating conditions like multiple sclerosis. That dose of high-dose corticosteroids is going to be effective. It's got to be high dose. It has to be for a long enough period of time. If you do that combination, yeah, dengue responds the same way that we've anecdotally been seeing here with West Nile virus. Now, the reality is that, dengue still targets people who live in countries that have very limited resources. That's where you can have 200 to 300 million cases in a year. Even the neuroinvasive forms of dengue, neuroinvasive forms that used to have really high mortality rates, over 50%. Those cases are based on, not because of the virus attack, it's the autoimmune effects of the virus. And it's almost a paradox because there are 4 major strains of virus. And if you come into contact with one strain, you do okay, West Nile virus. If you come into contact with a second strain, then you can develop what used to be called dengue toxic shock syndrome, or dengue hemorrhagic fever. It's a combination of both the virus that attacks, the second dengue virus, or the third dengue virus that attacks, and the underlying immune system. So you're going to have, it's going to be an autoimmune, they call it a cytokine storm. Go back to what I was showing, those algorithms. The cytokines were up there. Cytokines are probably what clearly contributed to Dr. Bush's, what must have been just a very bad neuroinflammation affecting her brain. Because 25 days later, it's not going to be the virus that's doing this. It's going to be her immune system, and that's what I was able to say to Dr. Sinclair and others. And I tell you, the Baptists now are very well trained. And it's not even because of me. They just wanted to know this is what we do, and now they're doing it on their own. The call that I got after Dr. Bush, they had already started high-dose steroids in a patient. Okay. Now I didn't have to intervene or anything. They wanted to learn. They knew that there was for Dr. Bush, you read what the neurologist thought. It really was flip of a coin whether or not she would survive it. Any other questions? Yes.
In my case, I lost my hearing.
Well, you know what? Should I be repeating this?
Yes.
Okay, I'm sorry. Okay.
I lost my hearing, and I forget how many, maybe the second week, third week, I couldn't hear it.
So you lost your hearing the first week or second week?
I lost my hearing. And I was in hospital.
From both ears or just one ear? Both ears.
They sent me to Rob, who put me on a decreasing form of steroid.
Okay, so the doctor treated you with a decreasing form of steroids, maybe a steroid dose pack?
Yeah, something like that.
Okay.
And then they continued that when I was released from the hospital for another couple of weeks.
Do you think that the steroids helped or had no really effect?
I was going to ask you if you felt that was high enough dose to have done any good. I did, it came back completely.
A couple of things. It's possible that the hearing would have come back completely anyhow. Okay, number one. In some cases, let me ask you, Megan, did we use high-dose steroids in you? Okay, so we did not.
I took like steroids, so my rash.
So that would not have. Yeah.
And so I had like a low dose steroid and I didn't know it was on.
Yeah, so that's probably what happened with you. So Megan's a good example of, she had elevated cytokines because we measured those in her blood. And she had something called tumor necrosis factor. It was elevated, and interferon gamma was elevated. And she had all these symptoms suggesting, neuroinvasive disease. But she got better on her own because I did not give her high-dose steroids. So yes, it can happen. Not the turnaround that we saw with Dr. Bush. I've never seen that before. And that's why, I mean, one testimonial, all you have to do is be there, and that's why Dr. Sadiq and Dr. Sinclair and the other group at Baptist are doing it now. They saw this. It's a marked turnaround. So Megan's turnaround, Megan improved, but it was a slow, methodical improvement, and she's still not completely back to normal. I know if you are. Okay, she's shaking her head this way. Any other questions, Mike?
Well, first of all, they told me I had a mild case. It go over well. I didn't have the case years with y'all, but still, it should have been a mild. They don't even need a mild.
So Mike is saying he was told he had a mild case. Now you have to know Mike. If you saw a picture of him, he's like 220 pounds of muscle, okay? And he works as a highway patrolman. He's promised to get me off my next ticket. Okay. But anyhow, he's saying they should have had, from going from mild to neuroinvasive, they should have at least a moderate category. Go ahead.
Anyway, a few things that I've noticed since, getting on most but my eyes are kind of jaundiced looking, never clear. Of course, the AM's eyesight goes, but I can't get glasses because the eyesight comes and goes and worse at times.
So Mike is having problems with vision, eyesight. He looks in the mirror. He thinks his eyes are maybe a little bit yellow. First of all, if you actually do believe that someone should have ordered liver function studies on you.
Well, I had a physical and the liver functions were,
Liver functions were normal? Yeah. So it's not going to be, it won't be jaundice, or shouldn't be jaundice.
And the other thing was my pulse rate resting and sitting down for 2 hours. It was high as 135.
And so, yeah, so his pulse rate sitting down would be as high as 135. That is clearly abnormal.
Well, they did a nuclear stress test, and my heart was fine. Well, they put me on the machine on this, injected me with the nuclear.
Right, yeah.
Then they put me on the treadmill. We took on like 15 minutes as high as it would go, level, and my pulse rate only got to 140. And I told the lady, I said, look, I don't have heart problems, I'm about to fall out. But they put me on, after that, put me on something to get my pulse rate down. But, you don't know whether to cut back on medicine or,
Yeah, it is tough. So I would venture to say that, maybe there was a post-infectious effect on your autonomic nervous system. We know the virus can do it acutely from autopsy studies. We know that, and from animal studies, and we know that, like Amanda, it can be delayed. Okay, so if this,
we always solve my problems, but
yeah.
I'll stay out there 10 minutes longer. When I said it's good hot.
So heat intolerance. So that actually is a good, not uncommon complaint, and the so-called trouble regulating body temperature. That feeling that you have trouble regulating body temperature. You have it, Megan. Others have given me very similar reports. No one's ever, to my knowledge, no one has ever written on it. It would also be under the pathogenesis would very likely be the autonomic nervous system being targeted, either directly during the viral attack or later on through autoimmune mechanisms. You're welcome. Yes, Michelle.
Are you seeing people 5-6 years out coming up with new symptoms that are, that's not symptoms, but they're new to them now?
So the question is, Ms. Hill wants to know if I'm finding patients 5-6 years out developing new symptoms, new neurological deficits. A couple of things. Based on the Houston reports, the ones by Rodrigo Hospital and Christy Murray, and the 2 programs, keep in mind the average duration of these symptoms was 5 years. So the reality is that you can actually have symptoms that are attributed to West Nile virus infection that linger for over 5 years, and that are attributed to a dysregulation of your immune system. So it's kind of you have a pro-inflammatory type of immune system. In terms of new, I would say the myasthenia gravis group and the patients with cancer. And by the way, I mentioned the association with tumorigenesis. And I think the biochemistry allows me to mention that because Dr. Bai and his group actually showed that OPN is essentially regulated up after a West Nile virus infection. So genesis is clearly a biochemical possibility. In fact, one would predict. I really can't say whether or not West Nile virus is, in the future going to be added as another virus that can, contribute to cancers down the road. Okay, I think it's going to take a study I cannot do. It's going to take thousands of patients. Then the biostatisticians are going to have to tweak out whether or not there's actually an association there. It's going to be hard. But no, I haven't seen anyone who came up with new symptoms. I'm going to mention one patient who in 2002 developed a severe bulbar West Nile virus infection, targeted his everything in the brainstem. Couldn't talk. Almost like this gentleman I saw you with that I showed the picture of with the tape. And I was probably 2014, late 2014, that he actually started developing what he thought were symptoms that he had in 2002. Okay, so I actually had been waiting for that type of case to present itself, and so I have enough records in this particular person that I suspect he's probably the first case of post West Nile virus poliomyelitis reported. Okay? I'm not sure, but I mean, he actually was convinced. Ironically, I did repeat all the blood work on him, and he actually, it came back with something very implausible. They thought he actually had an IgM antibody, which, but when I repeated it with other labs, the lab that performed the antibody told me it was positive. Actually, we did it at 3 different labs, and 2 of the others were negative. So it's one of the issues is that when something doesn't make sense, you really have to repeat the lab work, the blood work. But this gentleman sounds to me like he was developing what I would predict would be a post-polio syndrome. There's a nice mechanism for that, and it makes perfect sense that some patients, Mr. Terry, I don't know, how you're doing, but Mr. Terry, Mr. Gibbs, and the gentleman I showed you, would be in contention for doing that. Any other questions? Susan.
I just remembered when we started reporting some of that there were some people that got it that were already on steroids because they were having other.
Oh, okay, so this is different. Yeah, this is different. The picture I showed of the West Nile virus, the S100B, the cytokines, the OPN, the HMGB1, all of that is part of the antiviral response. It saves people. The problem is when it lingers and why it lingers and why it's protracted. And why the Houston group found that, hey, 5 years later, 1/3 of you with symptoms have all these high cytokine levels. That shouldn't be. It's probably a dysregulation that preceded the infection. It's less likely the virus actually changed their immune system, but maybe I prefer to think that the virus is somehow selecting the people who have this particular problem to begin with. So these individuals just keep these high pro-inflammatory proteins up for too long a period of time.
That was going to be my question. So from what it sounds like, most people that end up in the hospital probably had a weak immune system to begin with.
So the question, the statement actually was that most people who come into the hospital probably had a weak immune system to begin with. That's a correct statement, okay?
So like moving now, like would their alternative to be to go to like an immune doctor? Like, because with all the different symptoms and stuff, like where would your best bet be to go?
So let me just refine your statement just a little bit. If you're immunocompromised for whatever reason, some type of hereditary immune deficiency, you have been on drugs that suppress the immune system, or you have underlying cancer or any other cause to have relative immunodeficiency, that's a bad thing. So but if you talk about patients in this room, did they have a known or identified immunodeficiency prior to West Nile? There's no evidence for that. Okay, I can't say that that's the problem, because we just don't know who these patients are. If you have a room full of 10 people and these 10 people are bitten by the same mosquitoes that carry the West Nile virus, we know that only 2 out of the 10 are going to come down with any symptoms. The other 8 are not. So is there something about the 2? Yeah, there's something about the 2 that became symptomatic. And now we know we're almost like studying after the fact. We're studying and we're checking. The Houston group checked for 5 years, in their group of patients, and these values, stayed up. So there is something wrong about their immune system in a lot of the cases. We just don't understand enough about the pathogenesis to say that, well, could I, if I got bitten, what are the chances that I would develop a severe infection? Elderly people get severe infections young. Okay, immunocompromised get more severe infections more than the young. It's probably, if they looked into it, they would probably have more likelihood of getting even West Nile fever compared to others, because of the relative immunosuppression that comes with just aging. So, but I can't answer your question. I don't know the answer. So who would you go to next? So you want to know, well, if it's an immune issue, do I go to an immunologist? I actually invited an immunologist to attend today, but he was actually streets of Chicago. And so maybe next I'll ask him earlier when we go to Hattiesburg to maybe attend. But the answer would be, yeah, I think an immunologist, I would personally go to a neuroimmunologist. So they could probably check, labs that I have never even considered checking. And probably better define exactly what's happening to your immune system. So actually, that's a very good comment. Okay. Yes.
Any correlation between the amount of virus in a particular bird, either picked up an injection to a particular person, would be significant?
Yeah, actually, the question was, does it matter whether the mosquito injects this much virus or this much virus? That's a really good question. I can speculate. First of all, whether they inject this much or this much, the viremic phase in humans that's the phase which the virus is circulating in the bloodstream, is very short, sometimes measured in hours, and the viral load is very low, very low. So it's not the viremic phase is, I have read that even if a mosquito bites you during the viremic phase, the likelihood of it being able to transmit the virus from you is still nil. Okay, so again, it's not a virus that likes the human body. You're a dead end host, whether they inject this much or this much. It's probably going to behave the same way, and I think other factors are probably going to take over, like the factor of why the dysregulation, why the persistent immune activation. All these things will probably be hopefully worked out in the next 20 years. I would mention the word vaccine, but that's a taboo word for me right now. Okay.
I actually have two things I want to talk to you about. One of them is I noticed on one of your slides, and I think it was on Amanda, a change in sweating.
Yeah, a change in sweating. So the issue is, he noticed that there was a change in sweating as a symptom. Yes.
I actually, I had West Nile in 2012, and
so you had West Nile 2012.
Fatigue bad enough, long enough that I don't know if it initially started there, because when I would get tired, I would push through it. But now that I'm stronger and like to consider myself more back to normal, I push through. But when I'm outside getting hot and I need to quit, I sweat profusely, and even though I'm calling myself staying hydrated, most Saturdays I can lose from Friday night to Saturday night on the scale, I can lose 6 to 8 pounds. And I know it's food.
So he's saying that on Saturday, on Friday to Saturday, he can lose 6 to 8 pounds, and he knows it's from sweating and fluid.
Is that what?
So let me ask you something. Just since we're talking openly here, so Friday and Saturdays are the drinking days, anyhow. Alcohol days.
I don't drink alcohol.
So you don't drink alcohol, period. Okay. So okay. So it's not that. It's not that. Okay. So actually, you have a very cogent argument for why you might be sweating it out. Yeah.
Right. And I when I was younger, I never used. I sweat. I always sweat when I'm working, but not to that.
So before West Nile, actually, you look pretty young. He goes when I was younger, but you actually look pretty young anyhow. So before West Nile, you didn't sweat like this, and now you do. I would say that's actually, that's not uncommon either. Okay, not uncommon. In fact, I will tell you.
Not uncommon in life?
No, not uncommon in West Nile. And furthermore, it's not uncommon in other diseases like Sjogren's. Sjogren's syndrome, a classic autoimmune disease, you can have hyperthermia hydrosis, that's increased sweating initially, and then later on, anhydrosis, an meaning no sweating at all.
Is there something that can be done for that or not?
Yeah, for the hyperhidrosis, yeah, they're actually treatments. Yeah. Yes.
I mean, I've asked
So,
my
so,
doctor about this.
so, no, but I've actually seen a few patients who have focal hyperhidrosis. It's an amazing thing to see because you don't believe it. One young lady who sweated from a little area of her forearm, and it would be dripping, like a little stream flowing, and that was it. So we were able to treat just by putting on antiperspirant, different types of antiperspirants right on that area where it was focal. You have some sweating issues. Yeah.
And if we do that.
No. So essentially, the parasympathetic controls a lot of the sweating mechanism. So you need a drug that's going to do anti-SLUD, anti-SLUD. So it's going to be anti-salivation, anti-lacrimation, anti-urination, anti-defecation. So the problem with trying to target one thing like sweating, there's no drug that I know of except for topicals that's going to essentially control that without having another effect on other systems controlled by the autonomic nervous system. Okay, I'll tell you what though, it's intriguing enough that I'm going to look into it.
My other point that I wanted to see if anybody else has is, now that I'm recovered from the worst part of, I think, my fatigue, and I push through it, I'm strong and going as long as I'm up and going. But just like sitting here today, when I stop, it's almost like I go into a coma for the first 15 minutes. I could not stay awake in here for 15 minutes. I went to with my wife yesterday, and when they called her for an appointment, she had to wake me up. She said, I wish I could do that. And I said, I wish I could not do that. But
So what you have is hypersomnolence. So a sleep disorder, sleep disruption is really common. It's usually in the sense of insomnia for the first few months after the infection. And then that generally improves a little bit on its own or with treatment. There's not any good sleeping aid that I recommend. I mean, the warnings came out just not too long ago about the whole gamut of medications.
I don't have a problem sleeping at night. I just have a problem staying awake when I sit down for a minute, and it's my problem. When I go to sleep at night, I'm asleep. I don't lay awake at night.
Wait a second. Hold on. So you sleep okay at night?
Yeah.
You wake up refreshed?
Yeah, when I got a new boss,
Yeah.
I started sleeping. Yeah.
Okay.
But that was a different problem.
Okay.
I knew what that was.
So I want you to look up a couple of conditions, okay? Look up narcolepsy. Narcolepsy. Have you ever?
Yeah, I've heard of that.
Okay, so look up narcolepsy. Look up C-A-T-A, cataplexy. Narcolepsy and cataplexy, sometimes they go together. So one is more of a sleep paralysis. The other, narcolepsy, a condition that you can kind of, your symptoms will fit into that possibility.
What was the cataplexy?
C-A-T-A-P-L-E-X-I-A. Okay. So look, and then just do me a favor. Call Connie in a couple of weeks, and then let me know. Yeah. Connie's my office manager. She was in here not too long ago. Well, okay, just call my office. Okay. Dr. Bush.
First of all, I'd like to thank you. I think saving my life won't.
No, I didn't save his life.
No, the two of you.
I know. You're welcome.
What I have been concerned with is you mentioned aging being a negative for this guy.
Yeah.
And you said something about anyway, I'm 72 years old. And one of the things you mentioned to your husband is that as you age, you're less likely to respond. So now let me just say this. I have done very well. I want to thank you that it's been several days, a couple of weeks since I've had any pain. I had a lot of pain when I first came home. And but now I have gone at least 2 full days without pain. So I'm very appreciative. Sing my voice. I used to sing in high soprano. Now, if I do alto, I'm doing good.
Okay,
But
okay.
I'm grateful that I can sing. Walking. I have been able to manage getting from the big wheelchair to a rollator, and now I use that along with the cane. I'm trying to graduate to a cane. I don't know if it's fear of falling on my part.
Okay, so let me just interrupt. Don't graduate cane. Yeah, I like the fact that you have improved and that you're very thankful, and you have made truly a remarkable recovery. Everything has improved, but I will tell you what I tell most of my patients. I kind of, as a physician, I feel better when you have a walker than you are relying on a cane.
Oh,
Okay, I think a walker is safer than a cane. A rolling walker is, in my opinion, safer. I see patients who come in not just for West Nile, obviously, but for other peripheral nerve conditions like foot drop and things of that nature. And when they get a certain age, the last thing I want, and I know it would be a major setback, would be a fractured hip. Okay, and you're a physician, you know that too, and you know that carries as much mortality as West Nile virus. Okay.
I'm always gonna cheer for you.
Yeah, that's true.
I actually bought a cane that had a fold-out seat on it.
My father has a cane with a fold-out seat. Yeah.
I think that thing
And so I would say safety first. If it's one of your goals, then I would say maybe alter it slightly so that if your goal was to walk around the block with a cane, then do something equivalent. Walk around the block twice with a walker. But again, with both hands, you're going to be more stable.
I appreciate this because I was thinking I was getting better if I was moving to a cane and eventually didn't walk without anything.
No, I don't mind you getting better, and if you don't need either a cane or a walker. You have one strike against you, okay, and that is that you're not getting younger. Gasps. Okay, you're just not getting younger. It's not going to get easier. And so I don't want you to test the limits of what you can do, because the first time you fall, that may be the time. Okay?
Thank you.
You're welcome, Ms. Hill.
I really want to add something that because of the fatigue, I did try exercise at the Y, and I couldn't keep up with it, even silver sneakers. Whereas older people, I couldn't do it. And so I stopped doing anything, and I was just tired. I'd sit there and I'd lay down, or see something and I'd lay down. Started exercising regularly 3 days a week about 9 months ago. I'd say I'm doing better now after 6 years. I really think I feel better. And it's a simple, it's I want to say older.
Okay. So your exercise program.
It's high school, we work every muscle in the body, and I would just encourage it.
So do you do this in a group? In a group?
Yes.
Okay, so what's the group called?
It's Mature Fitness.
Mature Fitness.
Mature Fitness, and
Okay, but do they do like, is this a form of yoga or what is this?
it's, we stretch
stretch, light weights. I'm okay with all that. In fact, don't get me wrong, okay? Because even if you didn't have West Nile virus infection, I would be saying what you're describing is probably good for your health anyhow. Your bones are going to be less brittle if you weight bear, less brittle if you actually exercise and do range of motion and do the low barbell weights. Those type of things are okay. Okay, that is part of a healthy routine, period. Okay, walking is part of a healthy routine. So it's just a little hard for me to encourage you, Dr. Bush, to go to a cane from a walker and then to no cane at all. If that's something you can maneuver on your own, then good, okay? But just kind of keep in mind, this is a good example. So essentially, she's kind of refuting what I just told you, but but it's good. This is okay. It's okay because it's okay because she's showing you that even I have no idea how old you are, and I'm not going to ask you to tell, but any type of structured exercise routine can be beneficial, probably at any age.
Well, I can tell you that last night, this man and I went to boot camp.
Boot camp.
2 days a week. For an hour, we exercised, and you could go to the YouTube and see him in particular. You probably see me sitting on the floor, but you'll see him running. And so until West Nile, this is what the two of us.
So until West Nile, they were going to boot camp together.
And so now he has to go because he's prepared to do that. I'll tell you this, it was a plus for him. 5:30, he gets up every morning. And for an hour, he takes me through exercises to help strengthen me. So I am starting to.
That's excellent.
I started to a lot of things.
Lee, good.
But I would just say, I got so excited because I was improving. So that's why I thought improvement was the cane and then nothing. You say improvement would be to go from the rollator to nothing.
No. I'm not saying. No.
I would
Look.
try to do nothing unless I thought.
Okay.
I could do it.
Okay. Now I don't want you to. Not necessarily that. Okay. I rather that you, if you can, safely transition from the walker to a cane. That's fine. But before you start taking the cane outdoors.
I'm not.
Okay. Before you start taking it outdoors, I would say on uneven ground, which I'm thinking boot camp would be uneven ground. I would say rethink that.
Boot camp is a gymnasium floor.
Oh, okay.
Yeah,
Never mind.
But no.
Okay.
I also have his purpose belt or whatever out my way. So even with the rollator, he walks with me with his hand on the back of the belt. So if I should lose my balance, he's there.
This is wonderful. That's really wonderful. Okay. Now you see why I could say, and the doctors at Baptist were okay with essentially putting her on high dose steroids to look for any type of her crashing because Lee was there, and it's like, oh my gosh, I mean, you're exceptional. Okay.
We've only been married 50 years. So.
We're going to take some questions from the webinar group. Okay, the first question. I have Lyme disease and had a meningoencephalitis, Lyme disease, and 8 years later, the AMAN, it's called acute motor axonal neuropathy variant of Guillain-Barré syndrome. 20 years later, I have a positive ANA and positive SSA and SSB. I'm sure you have a chronic persistent sickness. I'm sure when you have a chronic persistent sickness, you can get immune disease. Now I'm in a university hospital and they are looking for Sjogren's. Can you also an autoimmune encephalitis from West Nile virus? Oh, wow, what a good question. Okay, so let's define this slightly different from before. The encephalitis with West Nile is clearly contributed to by massive neuroinflammation. Okay, define that as an autoimmune disease, not like lupus or rheumatoid arthritis for the time being, but your immune system does cause a massive inflammation, neuroinflammation that can give you an encephalitis. By definition, an encephalitis is inflammation of brain tissue. But I think what you're referring to is there are actually some immune antibodies that can also cause and target cause an encephalitis in the human brain. For the most part, these antibodies are probably already being screened for in the hospital that you're in. And they're looking for Sjogren's. You have, listen, if they're looking for Sjogren's, they have to do one more thing. With your constellation of abnormal positive ANA, SSA, and SSB, you need a lip biopsy. You need a biopsy of the minor salivary glands. That probably is going to be the most, I would probably say, I would not probably give you a diagnosis of Sjogren's until you have that. If you have the called SICA, S-I-C-C-A symptoms, S-I-C-C-A, SICA symptoms, that's dry eyes, dry mouth, and a positive SSA, positive SSB, they're probably going to want to give you a diagnosis of Sjogren's. I'll probably say to you that the most important test for diagnosing Sjogren's is a minor salivary gland biopsy. And so I want you to take your tongue and run it along the bottom of your lip, not this lip, but underneath. You feel all those little bumps? Those are the minor salivary glands. That is what needs to be biopsied. And they're going to have a score that looks at inflammation in those minor salivary glands and will give you a very important clue as to whether or not you actually have classic Sjogren's disease. You've had other conditions here. I'm not going to talk about MAN. I would say the combination of Lyme disease causing a meningoencephalitis, depending on where you live, I would probably, if you live in Lyme, Connecticut, I would say that's possible. In New York, it's possible. Even on the West Coast, it may be possible. If you live in Mississippi, it's highly, 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 highly unlikely. We can go an entire year and not have a single case of Lyme disease in Mississippi. So I'm going to leave that for the time being. The AMAN variant of Guillain-Barré syndrome is really tough. Okay, that can also mimic poliomyelitis. Okay, and so if you had the AMAN variant, you would have been placed on IVIG or plasma exchange. So hopefully that answers that question. This is, you're obviously from out of state. You're actually, no, I'm sorry, your last name is like Swedish. So maybe you're from Sweden or one of those countries. And so hopefully, proceed with the lip biopsy and go from there. Next, Ms. Myers, I'm forever arguing the immunity issue. Are there publications I could share related to this? Yes, there are. So look up my name, Leis, L-E-I-S, and there are publications and if they're not free to you, I can go ahead and send you a copy. If you send me your email, I will go ahead and send you a copy on several articles that actually provide a compelling argument for this post-infectious, pro-inflammatory state. And they're actually mentioned in these articles. Okay? So how would she contact me? So go through Sharon Stone. Go through Sharon Sims. Focal encephalitis. Go through Sharon Sims at MIA, Mosquito Illness Alliance.org. And then she'll go ahead, Ms. Myers, and put you through in contact with me. So next issue, I have no sound.
It's okay.
Oh, never mind. I think that's a technical one. Okay. Next one. Would IVIG therapy be beneficial if done months to several years post WNV? The answer could be yes. In Amanda Young, and she's actually accessible through MIA, also the Mosquito Illness Alliance. Yeah, she started IVIG in 2015 and had a really good outcome. And that was at least 2.5 years after the acute West Nile illness. Oh, I live in Holland. Many thanks, doctor. Okay. So, Miss, I'm gonna butcher it, but Wingarden. Yeah, go ahead and contact me. I'd like to just keep in touch and find out what you have. So this is where you got Lyme disease also in Holland. Yeah, that's, by the way, you have a beautiful country. I love the canals. Okay. Okay, let's keep on going. I think that's it. Okay, I think that's going to conclude it because, you know, I said Sharon Stone and MIA, I was thinking missing in action. And so I think I need some food or something. So thank you very much for attending a 20th anniversary. Okay. And we're straight for a strawberry. And by the way, we have all this food here. It's a crazy boy.